Good evening, everyone. Today we are going to discuss about one of the common extracranial solid tumor of the childhood, that is about neuroblastoma. So, if we talk about neuroblastoma, they are as I already mentioned, these are the most common extracranial solid tumor. And then, if you talk about high risk neuroblastoma, mm, so the cure rates that are seen in developed countries are around less than 40%. Then, what are the factors that are responsible for dismal outcomes in India? They include late diagnosis, malnutrition, limited availability of stem cell transplantation, uh, and the treatment abandonment. So, if we talk about the clinical feature of neuroblastoma, so around 90% of these cases are diagnosed within a age group of 5 year of age, and they can originate from anywhere along the sympathetic chain, presenting as a mass which can be arising either from a neck, mediastinum, abdomen, or pelvis. Then nearly two-thirds of the primary tumor occurs within the abdomen. Then what about metastasis? So metastases are common, and they commonly metastasize to the or spread to the regional lymph nodes. And distant metastatic site includes bone marrow, cortical bone, and liver and skin. So remember this thing, because this is going to have a bearing on the staging of the disease. Then paraspinal neuroblastoma can lead to compression of the nerve roots and the spinal cord, and associated symptoms can be there. Then what about the paraneoplastic syndrome? So one of the common paraneoplastic syndrome that are seen in neuroblastoma, one is OMAS, that is opsoclonus myoclonus ataxia syndrome. Then second is intractable watery diarrhea that is seen with these children. Then one of the another thing that can be associated with these lesions include the hypertension, which can be managed with antihypertensive medicines, and it usually resolve with the chemo reduction. When we give chemo, there will be a reduction in the tumor size, which can ultimately lead to will tackle the hypertension. Or either, if it is a resectable tumor, then surgical removal of tumor can help. Then if we talk about diagnosing this illness, so the diagnosis is usually done by a pathological diagnosis from tumor tissue, pathological diagnosis from a tumor tissue by light microscopy, then which can be either with or without immunohistochemistry. Then raised urine or serum homovanillic or vinyl mandelic acid. So these are supportive. Then IHC can help in distinguishing from the other small round blue cell tumors. Then biopsy is usually done by a true cut needle under image guidance, and the material is utilized for two things. One is for histopathological grading, and another one is for prognostic markers, that are MYCN amplification. Then the tumor biopsy may be difficult in circumstances such as when there is a vital instability, or either patient is having thrombocytopenia or coagulopathy, or if there are paraspinal masses, or sometime because of logistical delays. So as we know that this disease have a high rate of bone marrow infiltration, which can be seen around in 60% of the patients. So we were talking about the biopsy, which should be utilized for histopathological grading and to know the MYCN status, and when it is associated with difficulty to get a tumor biopsy. And then we were talking about the bone marrow infiltration. So bone marrow infiltration is usually seen in 60% of these children, especially when the in a more than 18-month old. An upfront bilateral bone marrow aspirate with trephine should be considered for a suggestive or a clinical or a radiological profile. So bone marrow biopsy, that trephine biopsy along with aspiration, and it should be a bilateral thing. Then the second thing, the diagnosis can be confirmed with unequivocal marrow infiltration by tumor cells, substantiated by the elevated urinary catecholamines. Then urine HV or VMA levels are supportive, and it is a non-invasive method, and random or spot urine samples are as effective as the 24-hour collections and seems to be more practical. So the radiological staging of the primary tumor is usually done by contrast enhanced CT scan. MRI is done for paraspinal lesions. So CT, one thing, MRI is for the paraspinal lesions. Then metastatic evaluation classically involves MIBG scan along with the bilateral bone marrow aspirate that we have already discussed. Then what are the minimum investigation that one need to do? So we can say what are the essential and the desirable investigations then one need to do while diagnosing or staging the neuroblastoma. So essential investigation include complete blood count, serum electrolytes, uric acids, bilirubin, liver transaminases, creatinine, because these are going to help you in getting all these imaging. And also if you want to start chemotherapies, then prothrombin time and APTT prior to invasive procedure. If one is planning biopsy, and the CT of the primary tumor with IV contrast, tumor biopsy with the IHC marker, bilateral bone marrow aspirate and trephine, then MIBG scan, and then MY gene amplification, especially in stage 4 tumor in patients with age less than 18 months, and for all the patients having stage 3 tumors. And then the serum LDH and ferritin when MYCN status is unavailable in stage 3 and less than 18-month old patient with stage 4. For if we talk about the desirable investigations, the desirable investigations include MRI in paraspinal tumors, as I have already discussed, then MYCN gene amplification and the urinary VMA and HVA levels, and then DNA ploidy in tumor tissue, and segmental chromosomal aberrations can be assessed. Then if we talk about what to choose between, if we have availability of both MIBG and FDG PET. So MIBG is the most sensitive in metastatic investigation for skeletal or for the soft tissue. So iodine 123 is the radiopharmaceutical of choice that is used for and has a favorable dosimetry and a superior image quality. But the availability of I-31 is usually available in majority of the centers in India. Whenever there is unavailability of MIBG, then one can go for technetium 99 bisphosphonate scintigraphy. that is bone scan, or FDG PET is performed. So FDG PET re-evaluation following chemotherapy is recommended either with MIBG or FDG PET. Then a bone scan is not ideal for the re-evaluation. So bone scan is not good for. And then in one of a recent study, it was found that FDG PET was superior to MIBG for detection of lymph nodes and bone marrow or bone base lesions. Then how to stage it and the risk stratification. So the staging and the risk stratification is done by we have basically two groups. One is called International Neuroblastoma Staging System, that is INSS, and the second one is called as International Neuroblastoma Risk Group Staging System. And they include various variables which include age, stage, histopathological grading, include age, stage, histopathological grading, serum lactate dehydrogenase, as we have already talked about the role of serum LDH and ferritin, then DNA ploidy, MYC and gene amplification, and then segmental chromosomal aberration. So these are the things that one has to know about. And then how MYCN and cytogenetic abnormalities plays a role in staging. So amplification of MYCN is observed in around 20% of the patients. 20% of the patients. And it is the single most important biological marker for risk stratification and treatment assignment. So MYCN is correlated with advanced, if there is a MYCN amplification, it is associated with advanced stage, unfavorable tumor biology, and poor outcome even in infants and in the lower stages. Then so MYCN amplification is defined as more than fourfold increase in the number of MYCN copies when compared to a control 2P probe. If we talk about MYCN further, it is a critical investigation in patients with stage 3 disease, mark my words, in stage 3 disease, and in patients with less than 18 months with stage 4 disease. So status of amplification in stage 4S will determine either one should go for therapy or either one should observation. So stage 4S, either therapy or observation. So status of MYCN would not alter the management in patients having age more than 18 months with metastatic disease who are already high risk. So in stage 1 and 2, MYCN amplification is usually seen in less than 5% of the patients. Hence, if it is unavailable, then one may be assured that it is non-amplified. Then if we talk about the role of serum ferritin and the serum LDH that we have just discussed. So serum LDH and serum ferritin, if the value of serum ferritin is more than 120 nanogram per milliliter, or the serum LDH is equal to a more than 750 international unit per liter, it acts as a surrogate marker for identifying high risk patients among the stage 3 and infants with stage 4 disease. Then how to treat it. So the treatment part we are going to discuss in a bit, while we discuss about the international neuroblastoma staging system. So the stage 1 include the localized tumor with complete gross excision with or without microscopic residual disease, representative ipsilateral lymph nodes are negative for tumor microscopically, which can be either the adherent lymph nodes, or while doing the excision of primary tumor they can be present along with that tumor. Then the stage 2A is localized tumor with incomplete gross excision, and representative ipsilateral non-adherent lymph node is negative for tumor microscopically. So one has to remember that there is an incomplete gross excision. And then stage 2B, it will be a localized tumor either with or without complete gross excision with ipsilateral non-adherent lymph node, that will be positive for tumor. That means the tumor is in the lymph nodes. So enlarged contralateral lymph nodes must be negative microscopically to say that it is a stage 2B disease. And if we talk about stage 3 disease, so stage 3 disease, when it is a unresectable unilateral tumor infiltrating across the midline, and midline means here the vertebral column. So if it crossing the midline with or without regional lymph node involvement, and localized unilateral tumor with contralateral regional lymph node involvement, or a midline tumor with bilateral extension by infiltration which is unresectable tumor or either by the lymph node involvement. Then if we talk about the stage 4 disease, so stage 4 disease is a primary tumor, any primary tumor which is disseminated to distant lymph nodes, bone marrow, liver, skin and or other organs except those are mentioned in stage 4S. Then we talk about stage 4S. Stage 4S include localized primary tumor as defined in stage 1, 2A or 2B with dissemination that is limited to skin, liver and or bone marrow, which is limited to infants less than 1 year of age. So if we talk about what is marrow involvement, so marrow involvement in stage 4S is defined as it should be less than 10% of total nucleated cells on aspirate and trophine, and more extensive involvement would be considered at stage 4. And if a MIBG scan has been done, it should be negative in marrow to call it as a stage 4S disease. Then if we talk about a few other variants like perinatal adrenal neuroblastoma. So perinatal adrenal neuroblastoma is usually detected antenatally or within the first 6 months of life. So that is called as perinatal adrenal neuroblastoma. And perinatal adrenal neuroblastoma have a overall survivor over 4 years is more than 95% with observation alone. That you have to remember. And 6 to 8 weekly monitoring with clinical examination. And USG is recommended till the resolution. So clinical examination and USG. Then or either progression dictating resection. So formal staging investigation may be deferred, which includes bone marrow aspirates or either MIBG until the child is of 3 months, or provided there is no increase in the size of the lesion or the urine BMA or HbA levels. Then a brief about paraspinal neuroblastoma. So paraspinal neuroblastoma are around seen in around 5 to 15% of the children, and they extend through the vertebral foramen, and they appear as dumbbell tumors and usually compress nerve roots and spinal cord. So dumbbell tumors are associated with younger age, greater frequency of thoracic primary and lesser incidence of metastasis. So remember, so dumbbell tumors are associated with younger age, younger age, then greater frequency of thoracic primary, and then the third is lesser incidence of meds. Okay, then what are the clinical manifestations? So clinical manifestation include back pain and the motor and sensory or the sphincter dysfunction, depending upon which part is involved. So motor, sensory or sphincter dysfunction. Okay, so then the neurological, if we talk about the neurological recovery, so neurological recovery is inversely correlated with the duration of symptom and sign. So neurological recovery is inversely proportional to duration of the symptom and sign. Then the urgent MRI and therapy are required if there is a cord compression. Indication for treatment in an asymptomatic paraspinal neuroblastoma includes if it is involving more than 33% of the spinal canal. So indication of treatment, or if it is involving more than 33% of the spinal canal, and if leptomeningeal space is not visualized, and if there is abnormal spinal cord signal intensity. So abnormal spinal cord signal intensity. So these are the things that we have to remember regarding indication of treatment in paraspinal neuroblastoma. So patients with sign of cord compression require urgent treatment, and upfront treatment has included either one can do a surgical laminectomy, radiotherapy and chemotherapy depending upon how severe the symptoms are. Then the laminectomy and radiotherapy can lead to scoliosis and spinal instability in the long term, which can be prevented with the help of chemotherapy with equivalent outcomes. Then laminectomy and laminotomy is preferable only in patients with a rapid neurological deterioration, and biopsy of the tumor is recommended after patient stabilization, and it should not delay the initiation of chemotherapy. So intravenous dexamethasone at a dose of 0.5 mg per kg bolus followed by 0.2 mg per kg per day in a divided dose is administered for the cord edema that is associated with these lesions. So the post first cycle a clinical radiological reassessment is done to assess whether there is any improvement in the further sign and symptom. And the second thing is after assessing this, one has to look for whether there is any lack of improvement, or if there is worsening of the neurological signs, or whether the intraspinal component has been reduced in size or not. Depending on these things, one should consider the laminotomy and the excision of the intraspinal component. So the two courses of the chemo, which include either the vincristine or the carboplatin, and are followed by cyclophosphamide, adriamycin or vincristine if disease is stable and improving with unresectable tumor. Then the stage 4S, which is very important type or the stage, I would say. So stage 4S, the survival in infants with 4S disease varies from 85 to 90 2%, and asymptomatic infants with more than 3 months of age can be safely observed till the spontaneous regression, and the respiratory compromise, liver dysfunction, uh, and the pedal or the scrotal edema, uh, or the significant emesis on follow-up will necessitate that it should be treated as one is usually treated for intermediate risk disease. And additionally, infants less than 3 months or old are best treated rather than observed, as they have high risk of progression. Okay, then so chemotherapy 2 to 4 cycle of which we have already mentioned is can be given as a standard modality, and treatment is continued till the baby becomes asymptomatic and disease show regression. Emergent radiotherapy should be avoided. A diagnostic biopsy is indicated for evaluation of tumor biology. Importantly, one should aware of what is the status of MYCN. And then subcutaneous nodule, if present, can be easily biopsied, and resection of the primary tumor does not seem to influence the overall outcome. So this is for today. In the next part, we will discuss about the chemotherapy managements and the various protocols that has been used for the management of neuroblastoma, which will include neuroblastoma 84 and the rapid Kojic protocols. Thank you.